And then we'll wait for a few more minutes and then we can start the session.
All right, sounds good.
Great. All right. Hi, everyone who's just joined us. Just want to let you know it's a couple minutes before noon, so we'll wait for a couple more minutes and then we'll start the session, okay? Deb and Chandrika, are we good to begin?
Yes, let's get started.
Okay. Let me... Okay, everyone, so I think we'll begin. Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's session is a collaboration between the Blum Center and Mass General Cancer Center. Before we begin, I'd like to go over a few items. Please note today's session is being recorded for educational purposes. If you're interested in viewing a recording of today's session, please visit our Blum Center website at massgeneral.org/Blum-Center. Everyone is in listen-only mode. We have muted everyone to reduce background noise so that we can hear today's guest speaker. If you have a question, feel free to use the chat feature at the bottom of your screen. Only the Blum Center staff, co-host, and guest speaker will see your questions. We'll have time to share them at the end. Please do not share any personal medical information or questions in the chat box. If you have a medical question, please ask your doctor. Next, I am going to introduce you to Devin Punch. She is the health educator for Mass General Cancer Center, and she is going to introduce you to today's guest speaker.
Hi, everyone, and welcome. Today is the first in a series of presentations from the genetic counselors in the Cancer Center, Cancer Risk Assessment Center. Our presenter today is Chandrika Kurpad. She has a master's degree in genetic counseling from the University of Alabama in Birmingham. Cancer genetic counselors have specialized training in genetics and counseling. They provide personalized help to individuals and families as they make decisions about their genetic risk for cancer. She will be speaking to us today about hereditary colon cancer. Thank you for being here. I'll turn it over to you now, Chandrika.
Thank you, Devin. Thank you, Amy. And thank you, everybody, for joining us today. Give me one moment to get my screen shared. Share. And let's see if this works. Yeah. Can everybody see? All right. Perfect. So I'm going to minimize this over here. Hold on. All right. I've got all my ducks lined up on my screen. Okay. Thank you for the opportunity to speak to you today about hereditary colon cancer, and thank you to the Blum Center for organizing this series from the Mass General Cancer Center on cancer genetics. I will be speaking to you today about hereditary colon cancer. So here's an overview of our discussion today. We will review the function of the colon and the rectum. We will review what colorectal cancer is. We will look at the differences between sporadic and hereditary colorectal cancer. We'll describe some hereditary colorectal cancer syndromes with case examples. We will discuss the benefits and limitations of genetic testing and identify individuals who are candidates for genetic counseling and testing. All right, so the colon and the rectum are part of the large intestine, the final part of the digestive system. The function of the colon is to reabsorb fluids and process waste matter and get it ready for elimination from the body. The colon, believe it or not, is about 5 feet long, and it starts right in this area where food empties into it from the small intestine. The colon extends upwards on the right side of the body as the ascending colon. Right around the liver, it makes a turn and goes across the body as the transverse colon. Right near the spleen, it makes a downward turn as the descending colon, and this final S-shaped part is the sigmoid colon. The colon ends in the rectum, which is a storage area for stool before it's eliminated through the anus. The terms colon cancer and colorectal cancer are used interchangeably. So what is colorectal cancer? It's an abnormal growth of cells lining the colon or the rectum that have the ability to invade or spread to other parts of the body, as shown in this figure here. So it starts out small, and as it grows bigger and bigger, it breaks through that basement membrane and spreads to other parts of the body. Colorectal cancer is the third most common cancer diagnosed in both men and women in the United States, and the lifetime risk for a person to develop colon cancer is about 1 in 20, or approximately 5% over their lifetime. Colorectal cancer usually begins as a polyp. A polyp is a growth on the inner surface of the colon or the rectum. Polyps are common, and often they're non-cancerous, but some can develop into cancer. There are several different types of polyps, and they're classified based on the way they appear to a trained pathologist's eye under the microscope. So hyperplastic polyps and inflammatory polyps are common, and typically these do not carry a risk of developing into cancer. Adenomas or adenomatous polyps can be further classified into tubular adenomas, tubulovillous adenomas, or villous adenomas, and these are common, but they're also precancerous. If left alone, meaning not removed during a colonoscopy, they can turn into cancer. Hamartomas are rare and usually are not precancerous except in rare situations, and serrated polyps may be precancerous if they're larger in size or you have a lot of them in your colon. So let's look at how a colon polyp grows into colon cancer. Now, the vast majority of colon polyps stay as colon polyps and do not develop into colon cancer. Most polyps begin as little bumps or protuberances in the inner lining, and if they're not removed, they're allowed to continue to grow as they get bigger and bigger in size. Some of the cells start showing signs of cancer, and this is called dysplasia. So as a polyp becomes bigger in size and starts getting more and more dysplasia, it begins the transformation towards a cancer and ultimately becomes an invasive cancer. Now, one of the key take-home points from today's talk is that regular colonoscopy screening, as recommended by your doctors, is a great tool to remove these colon polyps before they progress to invasive cancer. And so it's always a good idea to review with your doctors the right age to begin colonoscopy screening and how often to do it. All right, so there are several risk factors that increase the risk for colon cancer. And before we review the specific risk factors, I want to say that just because a person has one or more risk factors does not mean that they're going to get colon cancer. And the opposite is also true. If a person is diagnosed with colon cancer, they may or may not have any of the risk factors that increase risk for someone to get colon cancer. So one of the biggest risk factors for anybody to get any cancer is age. Most cancers are diagnosed when people are at older ages, and increasing age does increase the risk for a person to get colon cancer. A person's racial or ethnic background is a risk factor for colon cancer. Risks are highest among African Americans and lowest among Asians. Individuals who are of Ashkenazi Jewish ancestry also have increased risks for cancer due to a specific genetic mutation, which we will review a little bit later in this presentation. There's lots of diet and lifestyle factors that can increase a person's risk of getting colon cancer. A diet that's high in fat, low in fiber, with lots of red or processed meats, with a low intake of fruits and vegetables does increase risk, as does physical inactivity, meaning not getting enough exercise, heavy alcohol use, as well as smoking. Now, diet and lifestyle factors are something we can control to reduce our risk of getting colon cancer. A person's history, their history of whether they've had colon cancer in the past, or maybe they've had some colon polyps, or if they have inflammatory bowel disease or type 2 diabetes, does increase their risk of getting colon cancer, as well as if they have a family history of colon cancer in close relatives. Even if those close relatives have had colon polyps, it does increase a person's risk for colon cancer. And the last category and the focus of our discussion today are rare hereditary cancer syndromes like Lynch syndrome or familial adenomatous polyposis, or FAP for short, that significantly increase a person's risk to get colon cancer. Now, before we dive into those syndromes, I want to spend a couple minutes reviewing a few concepts that are key to understanding hereditary cancer. Number one is that all cancer is genetic. Whether it's sporadic or familial or hereditary, all cancer is genetic. It is caused by mistakes that accumulate in genes, in our DNA, in one to several cells of the body that lead to uncontrolled cell division and growth, and that is the formation of a tumor. Most of these changes are called somatic changes, or they're acquired during a person's lifetime, and they cannot be passed to the next generation. All cancer is not hereditary. Hereditary cancer means that an individual was born with a gene mutation in every cell in their body. This increases their chances of developing cancer during their lifetimes. These changes are called germline mutations. Now, just because a person is born with a germline mutation in a hereditary cancer syndrome gene does not mean that they're going to get all the cancers, because having that mutation does not guarantee it. There's other genetic, environmental, and lifestyle factors that all contribute to a person's risk. But having that germline mutation gives them a baseline increased risk to get one or more types of cancer. I also want to review the differences between sporadic and hereditary cancer in a little bit more detail. Now, we've got our genes come in pairs, because when we're born, we inherit one copy of most genes from mom and one from dad, right? And our bodies have thousands of genes that perform lots of different functions. We've got genes that are called tumor suppressor genes. These genes control how cells grow and divide. They fix mistakes in DNA, or they program cells to die when they've accumulated too many mistakes in their DNA. So let's suppose, so look at sporadic cancers in the top half of this slide. In sporadic cancers, this is a cell, and a person has got two normal copies of a tumor suppressor gene. Both copies are working as they should. As time goes by and the cell is exposed to environmental factors, it may get a mutation on one copy of this tumor suppressor gene. This increases this person's risk to get cancer. And as more time goes by and further exposures happen, the second copy of this tumor suppressor gene may also acquire a mutation. When both copies of a tumor suppressor gene are mutated, this accelerates the process of tumor development. In hereditary cancer, what happens is a person is born with one copy of this tumor suppressor gene already having a mutation in it in every cell in their body, and that's what makes their baseline risk to get cancer increased. So it takes a lot less time for environmental exposures during their lifetime for that second copy of that tumor suppressor gene to gain a mutation on it. And this accelerates this process of tumor development. This is why in people who have a hereditary cancer syndrome, or in families who have hereditary cancer syndromes, we see cancers diagnosed much more frequently and at younger ages than you would expect in a person who doesn't have that mutation. All right, looking at the distribution of cancer, most cancer is sporadic, meaning that these cancers occur due to that accumulation of mutations during a person's lifetime. The cancer occurs due to chance, or it's related to environmental factors. And this represents the general population risk for anybody to get cancer. In familial cancers, you may see multiple genes with small effects, as well as environmental factors that may be involved in the development of cancers in a family. There may be some increased risk for cancer. Only about 10% or so of cancer is hereditary, meaning that these cancers are due to changes in a single gene that's being passed down in a family and causing the people who inherit that particular gene change to have a significantly increased risk of cancer. In cancer genetics, we use a representation of a person's family history as a family tree to help guide us in the diagnosis of hereditary cancer. It's a very helpful tool. We compile a thorough family history comprising 3 generations of people on both sides of the family. Males are generally represented with squares. Females are represented as circles. And all 3 generations of a family are recorded. So these are the parents, these are their children, and these are their grandchildren. And typically we record individuals on both sides. We also identify who in the family had cancer, what type of cancer they had, and how old they were when they were first diagnosed with that cancer. We also record non-cancer features like the number of colon polyps that one or more people may have had in the family. So recording this family tree also helps us determine what genetic testing may be the best for this family and who in the family may be the best person to begin testing. In general, we like to start genetic testing in a family with a person who's had cancer because the likelihood of finding a mutation is higher in someone who's had cancer as opposed to someone who's never had cancer. So this is what a sporadic pedigree would look like. So here are all the individuals represented in this family, 3 of whom have been diagnosed with cancer. This person's colon cancer was diagnosed at age 82, which is a typical age when cancers are diagnosed. And with sporadic looking family histories, the cancer may be explained by an exposure. For example, this lung cancer may be explained by a history of smoking, or the skin cancer may be explained by a history of sun exposure. In a family tree that's suggestive of a hereditary cancer syndrome, we see multiple individuals in multiple generations diagnosed with cancer, often at younger ages, sometimes even under age 50 in the family. We see individuals such as this person here with multiple diagnoses of cancer, and the types of cancers we see in a family may clue us in as to the specific hereditary cancer syndrome that's suggested. So what is the purpose of classifying the risk into sporadic, familial, and hereditary? The classification serves the purpose to decide what would be the most appropriate intervention for the individual or their family members. So for example, if the family history looks sporadic and a person has an average risk of colon cancer with no other risk factors, we would recommend standard screening, which typically says begin colonoscopy screening at age 50. If a family history looks suggestive of familial cancers and there's a moderately increased risk for colon cancer, for example, if there's an individual who has a close family member, like a first-degree relative with colon cancer, we may recommend that they begin colonoscopy screening at age 40 or 10 years younger than the earliest age of diagnosis of colon cancer in the family, and go at least every 5 years for colonoscopy screening. If that risk appears hereditary and there's high risk, a referral for genetic evaluation is made, and after that evaluation, personalized screening and prevention recommendations are made. These are specific to the cancer syndrome or the specific gene that has a mutation on it. And so, which brings me to another take-home point from today, is it's really important that for a thorough risk assessment, it's great to have detailed information on a person's family history of cancer. And it's really important that each person know their family history of cancer or colon polyps and share this information with their doctors or healthcare providers so that the best screening plan can be developed for them. And if necessary, they may be referred for genetic counseling. All right, so let's look at the specifics of colorectal cancer. Most colorectal cancer is sporadic, about 60%. About 30% is familial, and only about 10% of colorectal cancer is hereditary. Within the hereditary piece of the pie, Lynch syndrome is the most commonly seen condition and accounts for about 3 to 5%. FAP, or familial adenomatous polyposis, accounts for about 1%. MAP, or MUTYH polyposis, accounts for about 1%, and other rare syndromes for the remaining. So a hereditary colon cancer syndrome means that we see several individuals in a family diagnosed with cancer at younger ages, multiple generations affected. We see a certain pattern of cancers in the family that are all attributable to a single underlying genetic change that increases the risk for all of these cancers. And over the next few slides, we'll study Lynch syndrome. We'll learn more about Lynch syndrome, FAP, and MAP using a case example each. All right, so let's start with our first case example on Lynch syndrome. So Jane is a 37-year-old woman that was recently diagnosed with colon cancer. She has a family history of colon and uterine cancer. Given her personal and family history of cancer, she was referred by her oncology team for genetic counseling. This is what Jane's family tree looks like. This is Jane with a diagnosis of colon cancer at age 37. Jane's mother has never had cancer, but her maternal aunt had endometrial cancer, which is the same thing as uterine cancer, at age 53. Jane's maternal uncle had colon cancer at age 42, and her maternal grandfather had colon cancer at age 59. Jane's colon tumor was analyzed in the laboratory, and it showed abnormal Lynch syndrome screening. Jane met with a genetic counselor and chose to pursue genetic testing, and her genetic test results showed that she has a germline mutation on one copy of her MSH2 gene, confirming her diagnosis of Lynch syndrome. So Jane was born with a mutation on one copy of her MSH2 gene in every cell in her body, and that is the underlying explanation for her diagnosis of colon cancer at age 37. So what is Lynch syndrome? Lynch syndrome accounts for approximately 3 to 5% of all colorectal cancer, and is the most common inherited colorectal cancer predisposition syndrome. It's quite common and affects about 1 in 280 people of all ethnicities. It is due to germline mutations in one of 4 DNA mismatch repair genes, including MLH1, MSH2, MSH6, and PMS2, as well as the EpCAM gene. Lynch syndrome is an autosomal dominant condition. What this means is that a mutation on one copy of a Lynch syndrome-associated gene is enough to cause the condition, and typically an affected person inherits Lynch syndrome from an affected parent. Lynch syndrome is associated with increased risks for colon and uterine cancer, those are the 2 major ones, as well as other gastrointestinal tract cancers, ovarian cancer, prostate cancer, urinary tract cancer, brain cancer, and skin cancer. Given that Jane has an MSH2 gene mutation, here are what MSH2 specific cancer risks look like. We'll focus on colorectal cancer. So everybody in the population has about a 4 to 5% chance to get colon cancer, and the average age, the median age at which colon cancer is diagnosed is usually in the mid-60s. If a person has an MSH2 mutation, that risk for colorectal cancer is significantly increased from 33 to 52%, and that age of diagnosis is lower. There's risks for several other types of cancers as well that are higher than the general population risks. So once we know that a person has Lynch syndrome and those increased cancer risks, we do offer cancer screening to try to reduce that risk of cancer, or to try to diagnose those cancers as early as possible when they're at their most treatable stage. So for somebody with an MSH2 mutation and that increased risk for colon cancer, for somebody with an MSH2 mutation and that increased risk for colon cancer, we recommend that they begin colonoscopy screening at age 20 to 25 and repeat it every 1 to 2 years. Medications may be recommended. That's chemoprevention to reduce the risk of getting colon cancer. And there's cancer screening to address the other cancer risks as well. So to wrap up Jane's story, we counseled Jane about her genetic test results and gave her a copy of her test report. We would refer her for her cancer surveillance. Here at MGH, we refer individuals with Lynch syndrome to Dr. Daniel Chung, who is our medical director of our MGH high-risk gastrointestinal cancers clinic. Jane was recommended to share her test report with her family members because her immediate family members, including her brother, her father, and her mother, each have a 50% chance to have that MSH2 mutation that was found in Jane. And if they undergo testing and find out that they have it, that would mean that they have Lynch syndrome as well, and they would need the cancer screening that's appropriate for their MSH2 mutation. If they test and find out that they do not have the mutation that was found in Jane, then we call them true negatives, meaning those increased MSH2-associated cancer risks do not apply to them. But their risk to get any kind of cancer is not zero. They still have the general population risks to get any type of cancer, and we absolutely want them to follow up with their doctors and get the cancer screening that's recommended for them. All right. So let's look at familial adenomatous polyposis, or FAP, using our second case example. So David is a 27-year-old young man who noticed he was passing blood in his stool. He was recommended to have a colonoscopy, and the colonoscopy screening revealed that he had more than 1,000 adenomatous polyps in his colon. Given his personal history of colon polyps, he was referred for genetic counseling. So here's a picture of what a normal colon looks like. And here's a picture of a colon with a lot of polyps in it. This is what David's family tree looks like. This is David here with more than 1,000 adenomatous polyps. But other than David's personal history, really nothing in his family looks suggestive of a hereditary cancer syndrome. His father had a skin cancer at age 60. He also had a lot of sun exposure. His maternal grandfather had prostate cancer at age 80, which is a very typical age for men to get prostate cancer. And his maternal grandmother had lung cancer at age 75, and she happened to be a smoker, and that was the likely explanation of her lung cancer. But given David's history of more than 1,000 colon polyps, he definitely met criteria for a genetics evaluation, and he met with a genetic counselor and chose to pursue genetic testing, and his genetic testing results showed that he had a germline mutation on one copy of his APC gene, confirming a diagnosis of familial adenomatous polyposis, or FAP. All right, so David was born with this germline mutation in every cell in his body. So what is FAP? It is also a hereditary colorectal cancer predisposition syndrome that accounts for approximately 1% of all colon cancers. It is due to germline mutations in the APC gene. It is also an autosomal dominant condition, meaning that in most cases, an affected person inherits the mutation from an affected parent. But in FAP, about 25 to 30% of people are found to have FAP with no family history of the condition, and we call such mutations de novo, or new mutations. There is a milder version of FAP called attenuated FAP, or AFAP. It has milder features, and they're seen at later ages. I want to spend a quick minute on a specific mutation in the APC gene called the APC I1307K mutation. This particular mutation is common among people who are Ashkenazi Jewish. It does not cause polyposis or FAP and only leads to about a 10% risk for colon cancer. Keep in mind the average risk for colon cancer is about 5%. So the APC I1307K mutation leads to about 2 times the colon cancer risk that the average person has. And the screening that's recommended is similar to those with a family history of colon cancer. So they do not need FAP-specific screening. All right, back to FAP. Now, people with FAP who do not have regular screening or risk-reducing interventions have a nearly 100% chance to get colon cancer. I want to repeat that these numbers are for people who do not have regular screening or any risk-reducing surgery or intervention. Those risks can be managed with regular screening and interventions. There's other cancer risks that we see in FAP as well, some small intestinal, pancreas cancer, some thyroid cancer, as well as other risks. In addition to cancer risks, people with FAP may also have certain non-cancerous features, such as bony growths called osteomas, dental problems such as extra teeth or dental tumors, and unusual pigmentation in the eye, which doesn't cause vision problems. It's called chopy. They may have gastric, meaning stomach, fundic gland polyps, and soft tissue tumors called desmoid tumors. So once we know a person has FAP and those increased cancer risks, we do recommend that they get cancer screening. Colonoscopy screening is recommended beginning at age 10 to 15 and at least every year. When those colon polyps become too many to remove with colonoscopies, then a colectomy may be recommended. And chemoprevention may also be recommended, which is medications to reduce your risk of getting colon cancer. There's other screenings for the other cancer types that we see with FAP as well. All right, to wrap up David's story, so we counseled David about his genetic test results and referred him to get his cancer screenings. We gave him back a copy of his genetic test report and recommended that he share it with his family members. Both of David's parents and his brother underwent genetic counseling and testing, and none of them were found to have that APC mutation which David had. And so the most likely explanation is that David is has a new mutation in the APC gene, which is the explanation for his diagnosis of FAP. But if David has children in the future, each of his children will have a 50% chance of inheriting that APC mutation from him. All right, so now let's look at MUTYH-associated polyposis, or MAP, with a third case example. So Mary is a 50-year-old woman with a history of colon cancer at age 40. She has no family history of cancer. She has 2 young children, and she's concerned about their risk of getting cancer. Given her young age of diagnosis of colon cancer and her concern regarding her children, her primary care provider referred her for genetic counseling. And here's what Mary's family tree looks like. This is Mary at age 50. She has a history of colon cancer at age 40. She has a son who's 25 and a daughter who's 20 years old. And really nobody in her family other than her has had cancer. So Mary met with a genetic counselor and chose to pursue genetic testing. And her genetic testing revealed that she has mutations on both copies of her MUTYH gene, confirming the diagnosis of MUTYH-associated polyposis, or MAP. So what is MAP? It is an autosomal recessive hereditary colorectal cancer predisposition syndrome. Autosomal recessive means that a person needs germline mutations on both copies of their MUTYH gene to be affected with MAP polyposis. In people who are of Northern European descent, there are two common mutations that are seen, and 1 to 2% of people are carriers, meaning they have a mutation on one copy of their MUTYH gene, not both. They do not have MAP polyposis. They may have a slightly increased risk for colon cancer, as we'll review in the next couple of slides. If a person has mutations on both copies of their MUTYH gene, they have MAP polyposis and an increased risk for colon cancer in the range of 43 to 88%. And once again, these risks are for people who have not had regular screening and or risk-reducing interventions. There's also risk for small intestinal cancer with MAP polyposis. So what are the screening recommendations for MAP MUTYH-associated polyposis? We recommend an affected individual begin colonoscopy screening every 1 to 2 years, beginning at age 20 to 25. And again, just like FAP, when those colon polyps become too many, a colectomy may be necessary. Chemoprevention with medications may also be indicated. And then for that risk of small intestinal cancer, an upper endoscopy every 2 to 3 years, beginning at age 30 to 35, may be recommended. So just a quick minute on those MUTYH carriers. These are individuals who have that mutation on one copy of their MUTYH gene. They're called carriers, and they do not have MUTYH-associated polyposis. 1 to 2% of Northern European individuals are carriers. They may have an approximately 8 to 10% risk for colon cancer. This depends on their family history. If they have a significant family history of cancer, then they may have up to a 10% risk of colon cancer. And screening is recommended for carriers based on their family history. All right, to wrap up Mary's story, so we counseled Mary about her genetic test results and referred her to specialists for her cancer surveillance. We recommended that her children receive their own genetic evaluation because at a minimum, each of her children is a carrier, meaning they will have a mutation on one copy of their MUTYH gene. Given that MUTYH gene mutations are common, we would recommend comprehensive analysis of the MUTYH gene for Mary's children. Each of Mary's parents are also carriers because Mary has mutations on both copies of her MUTYH gene. She got one from dad and one from mom. And therefore, each of her siblings, her brother and her sister, will have a 25% chance to have mutations on both copies of their MUTYH gene and have MAP polyposis, just like Mary. They have a 50% chance of being carriers, meaning having that MUTYH mutation only on one copy of their MUTYH gene. And they have a 25% chance of being neither a carrier nor affected with MAP. And so genetic counseling is indicated for all of them, as well as other members in the family. So there are many genes associated with colorectal cancer risk. We reviewed some of them in detail. We're not going to review every one of these genes on this table. The main points I want to make here is that there are many different genes associated with increased risk for colon cancer. And among hereditary colorectal cancer syndromes, there is a lot of overlap in features that we see with the different syndromes. And so nowadays, what we do is we offer genetic testing for many different genes, all associated with colorectal cancer, all at the same time on what are called multi-gene panels. And we've come a long way in cancer genetics. Between 1996 and 2006, we used to do testing for a single gene or a single syndrome. Between 2006 and 2013, we saw a lot of improvements in gene coverage and sensitivity of genetic testing. And then in 2013, the US Supreme Court ruled that genes may not be patented, and a lot of testing labs started offering testing for an inherited risk for cancer. 2013, incidentally, was also the year that Angelina Jolie published her op-ed in the New York Times about her BRCA1 mutation, which definitely increased awareness that cancer risk may be associated with hereditary cancer syndromes and gene mutations that may be inherited in a family. So between 2013 and 2018, we've seen an increase in the uptake of these multi-gene panels, which is testing many genes associated with cancer risk all at the same time. And here is a picture of several different options offered as multi-gene panels at a leading commercial laboratory. These panels and genes can become overwhelming for individuals and families. So during our pre-test genetic counseling session, we review with an individual or family what this testing would mean, and we help them make the choice as to the right genetic testing option for them. So as part of that pre-test genetic counseling session, we review a person's individual and family history of cancer. We discuss what impact the genetic test results may have on their cancer risk and on medical management of those risks. We talk about the psychological implications. Would those genetic test results give them a peace of mind, or would they make them more anxious or make them feel vulnerable? Would they have to make difficult decisions about communicating with family members? Genetic test results may affect family dynamics because it can be upsetting and challenging to tell family members that you had genetic testing and you were found to have a mutation in a high-risk gene and that they need to go do their own genetic testing. Parents may feel guilty about passing a mutation on to a child. So we discuss and help individuals and families cope with these. The information can be very scary, but we try to help them understand that it can help them and their family members to better manage their cancer risk. And that information can be very helpful. Insurance coverage is very important as a concern for many people. They all want to know, will my insurance pay for this test? The cost of genetic testing has come down a lot. And so nowadays, some people choose to pay out of pocket if their insurance does not cover it. And then we review confidentiality and insurance discrimination issues that come up with with genetic testing. In 2008, a federal law was put into place called GINA, or the Genetic Information Non-Discrimination Act. Under this law, health insurance and employment are protected, meaning a person's genetic test results cannot be used to discriminate against them for coverage and policy-related issues with health insurance and for hiring and firing decisions associated with employment. There are a few exceptions to that, but this GINA law does not cover everything. Life insurance, disability insurance, and long-term care insurance are not protected under the GINA law, and sometimes an individual may choose, if they're looking for a new policy, say a life insurance policy, to put that in place before they go ahead with genetic testing. So once a person has genetic testing, results can come back one of three ways. The test result may be positive, it may be negative, or it may be a variant of uncertain significance. A positive test result means that a mutation was identified in a gene and that increases that individual's risk to get cancer. A negative test result means that no mutations were identified in any of the genes tested that were associated with that increased risk for cancer. And then a variant of uncertain significance means that a genetic change was identified, but we're just not sure how meaningful this change is and whether there is cancer risk associated with it at all. So once we have these three test results, what do we do with them? With a positive test result, we use that result to guide medical management based on the specific cancer risks associated with that specific gene in which that individual tested positive. And we recommend that that individual share his genetic test or her genetic test result with their family members, and encourage those family members to seek out their own genetic counseling, because they may be at increased risk to have those to have that mutation and those associated cancer risks. With negative genetic test results or variants of uncertain significance, we set both of these aside as negative and do not use these results to guide medical management. We do not make clinical management decisions based on variants of uncertain significance. We fall back to a person's personal history and their family history to guide any cancer screening recommendations. We also typically do not test family members for these variants of uncertain significance. So to summarize the take-home points from today's presentation, most colon cancer is sporadic, only about 10% is hereditary. Lynch syndrome is one of the most common hereditary cancer predisposition syndromes, with risks for colon, uterine, and other cancers. There are other rare hereditary colorectal cancer predisposition syndromes that may be associated with polyposis. And the most important take-home message of today: know your family history of cancer and colon polyps in your immediate family, in your close family relatives, and your slightly distant. So we say know 3 generations worth of family history. So your immediate family would be your siblings, your parents, or your children, and then 1 step removed and 1 more step removed from that. So going all the way up to aunts, uncles, cousins, and grandparents. We like to know who had cancer in the family, what type of cancer they had, and how old they were when they were first diagnosed. Same thing with colon polyps: who had colon polyps, how many colon polyps, what type of colon polyps, and how old they were when they were first identified. And make sure that your healthcare providers are given this information so that they can create an individualized screening plan for you, and if indicated, you may be referred for genetic counseling. So genetic counseling is indicated if you have a personal or a family history of a known mutation in a colorectal polyposis or cancer gene, if you have a personal or family history of 10 or more adenomatous polyps, 2 or more hematomatous polyps, or 5 or more serrated polyps, if you have a personal history of a cancer diagnosed at any age with the tumor showing abnormal Lynch syndrome screening, if you have a personal history, meaning you were diagnosed with colon cancer or uterine cancer under age 50, or if you have a significant family history of Lynch syndrome related cancers. Here are some resources for more information. This is our MGH-CCRA website. A lot of the information that we give patients as handouts is available on our website, and it's a great resource for more information. The National Cancer Institute and the American Cancer Society provide great information as well. Hereditary Colon Cancer Takes Guts and Lynch Syndrome International are 2 resources that are specific to hereditary colorectal cancer syndromes. I want to put in a quick plug for upcoming cancer genetics presentations by my colleagues. There'll be a talk on ovarian cancer on Monday, August 3rd, a primer on cancer genetics on Tuesday, August 25th, the importance of knowing your family health history on October 16th, and a presentation on breast cancer genes on Tuesday, October 20th, and I hope you will attend all of them. This is my amazing team. We're all awesome. Dr. Leif Ellison is the director of our breast ovarian cancer genetics clinic. Dr. Daniel Chung is the director of our high-risk gastrointestinal cancers clinic. Kristen Shannon is our director of the cancer genetics program at the MGH Cancer Center. And all of us are genetic counselors. at the CCRA. It's a great team to work with. Thank you so much for your attention, and I am happy to take questions.
Thank you so much, Chandrika, for your informative and thorough presentation. We do have some questions in the question box.
All right.
I'm interested to learn more about how patients can predict and afford the cost of hereditary testing in cancer treatment, especially if there are cost gaps after accounting for Medicare, Medicaid, and private insurance coverage.
So that's a great question, and cost is absolutely one of the top concerns that many individuals have when they're thinking about getting genetic testing. Most insurance, we've come a long way in insurance coverage for genetic testing, and if you meet criteria for genetic testing, typically insurance will cover it, but with the way each insurance is structured, it's not possible to guarantee that they will. And so to safeguard against any surprises in billing, we can put a bill hold on a test, submit the test, and the genetic testing laboratory will review with the patient's insurance if they have any out-of-pocket cost. And then the patient can be apprised of that cost and either say, yes, I want it, or no, I don't. And then we can move forward with genetic testing. And the cost of genetic testing has come down a lot. Nowadays, you can get testing for as many genes as you want in the cancer realm for approximately $250.
Thank you. Another question, are you still able to perform your evaluation if parents and grandparents are deceased? My father had colon cancer and passed away 10 years ago. I'm the child and my children are the grandchildren. Can we still be evaluated for the grandchildren and for future generations?
Absolutely, yes. We are evaluating you when you come in for your genetic counseling, and we will ask questions about your family history and record who in the family had cancer, what type of cancer, and how old they were. And absolutely, we can evaluate an individual for a hereditary risk for that colon cancer, even if the individuals who had that cancer in the family have passed away.
Thank you. We have a couple of questions about variants on specific genes, so I hope that I'm reading these correctly.
Okay.
Able to discuss screening recommendations for C470T variant on CHEK2?
I'm sorry, you were breaking up. Can you repeat those gene names again? C for CHEK2 is that
yes.
what I said? Okay. So CHEK2 is a colorectal cancer risk gene. The average risk for a person without a CHEK2 mutation is about 4 to 5%. If that person has a CHEK2 mutation, then their risk is approximately 2 times, meaning approximately 10%. And for a person who has that CHEK2 mutation, we do recommend that they start colonoscopy screening at age 40 and go at least every 5 years.
Is there any elevated risk with C28G on the variant TP53? Hope I'm reading that correctly.
I'm not sure about that specific mutation. I would have to look that up. But the TP53 gene is associated with Li-Fraumeni syndrome, and there are increased risks for several different types of cancer with TP53 mutations, including colorectal cancer. For that specific mutation, I would have to look that up before I give a more appropriate answer.
Thank you. And we can try to follow up.
Absolutely.
If you would like to email, if there are any other questions that pop up,
yes.
You can email the Blum box. I don't know if we can put the email in here as well. It's pflc@partners.org, and we can follow up with answers to that. We do have a few more minutes if there are any other questions. And today's session, just as a reminder, has been recorded for anyone that may have missed it, or if you'd like to look back on it, we'll post it on the Blum Center website. And Amy has included the link in the chat box as well. Just a minute for any other last minute questions. Looks like we have another question here.
Okay.
My father has colon cancer for the second time. He is 81. His mother died of it at 72. If I choose not to get genetic testing, is it wise to wait every 5 years for a colonoscopy? I've had one polyp removed.
So that's an excellent question. And my first recommendation would be, given that your father had colon cancer twice, and his mother passed away from it, my first recommendation would be to get that genetic evaluation. I don't know anything else about other cancers in your family. It would be important to do a thorough review of your personal and your family history before making any recommendation for colonoscopy screening.
Thank you. And we have one last question, time for one last question, and then we will wrap up today. If you are adopted with unknown family history, can you qualify for genetic testing from your insurance? Are pathology results enough to qualify for genetic testing for FAP, MAP, and Lynch?
So definitely, if a person has tumor screening and that pathology report shows that that Lynch screening was abnormal, yes, that is absolutely an indication for a genetic referral, and insurance should cover. I never give guarantees with insurance coverage because that's an impossible task, but they should cover it because it does meet criteria for a genetics referral. And with FAP and MAP as well, if there's a lot of colon polyps, more than 10 adenomatous polyps in that colon, yes, that individual meets criteria for a genetic referral. And one would hope that their insurance would pay for it. In most cases, they will and they should, but again, no guarantees with insurance. And I think there was something about that. If a person is adopted, no, we did address. Oh, yeah, if a person is adopted and has no information about their family history, then it may be a good idea to consider genetic testing. But again, that should be done in the setting of a genetics referral, meeting with a genetic counselor for a thorough evaluation of their personal history and discuss their motivations for seeking a genetic test. They review the risks, benefits, and limitations of genetic testing and help that individual make an informed decision before getting that genetic testing.
Well, thank you. Thank you everyone for joining us today and for your questions. And thank you, Chandrika, for your wonderful presentation.
Absolutely, it's been a pleasure. Thank you very much for inviting me.
Thank you. Goodbye, everyone.
Bye.